But nonetheless, it's very important because most of the developed countries is a part and parcel of their daily practice. Now, ethical issues in palliative care, challenges and considerations. And this is how I'm going to discuss today. First, I will briefly mention about the concept. This has been, I think, talked about a lot, about concept and philosophy of palliative care. And after that, I'll be talking the principles of palliative care. That's the ethical principles. In that one, I will include end-of-life care, good death versus bad death, and the framework for it, and ethical framework in the end-of-life care, and challenges and conflicts in palliative care, and finally, conclusion. So coming to the concept, as everyone has already been informed, is about holistic support to the patient and family in terms of physical, emotional, and spiritual needs. And it also talks about improving the quality of life by managing the symptoms. And it also talks about whenever we do it, it should be patient-centered. That means it should be in the interest of the patients or the family members. Now, just to distinguish between the palliative care and the hospice care. So palliative care is the one that we just talked about in conjunction with the curative care. That's a broader concept. But when we talk about the hospice care, it's about the specialized palliative care, usually given at the end of the life care. So these are the two sort of differences that we have. And these are the key components for the palliative care. One is the symptom relief. That's has been talked about a lot to improve the quality of life and support emotionally, psychologically, and spiritually. That is another component. There's a sort of qualitative. And third component, which is very important in palliative care, is there should be effective communication. Without effective communication, everything will go haywire. Second one is it is always better, rather it should be mandatory for the palliative care providers or the team to include the preferences, the beliefs, the culture of the family and the family member, and there should be a coordination for a seamless care. Without these components, palliative care delivery will not be successful. Now coming to the ethics, the first one is autonomy. Autonomy means respect for the person. Because of autonomy, we take consent. So consent is very important in palliative care. So when we talk about consent, is respecting the patient's one, and we have lots of problem here. We have the surrogates, LAR. LAR means legally authorized representatives, decision, then consideration of the advance will, or the advance directive or the living will. Advance directive is something that a patient, when he was well, he said he will be giving that I would not like to be in the ventilator, for example. I don't want it CPR when I was in that condition. That's sort of his preferences. He put it while he was okay, and that is being followed when he is in the comatose or in some other state. That is what we call as advance directive or living will. Even in some of the hospitals in the Western countries, they practice this one, and some of the people do it. It's not that popular even in the Western country as of now, but we can think about it. It's a good thing to do. The most important thing is about consideration of the family dynamics, beliefs, culture, religion, and the patient's preference. Autonomy in the Western society is very strong. It's very individual. Once the individual doesn't agree at all, the doctors are provided they can't do anything. But here in our bloc, in the Eastern Bloc, it's a little compromise. The decision is sort of a collective, taken together by the family. Sometimes even the patient doesn't want it, the family wants it, and we go for it. So in that way, it's a little compromise. So all these things have to be considered, and while doing that one, we had lots of conflicts in the decision making. I'll be highlighting later on. Next is about the beneficence. So whatever treatment, whatever palliative care we are giving, it should be in the best interest of the patient. That is about the utility or the futility of the treatment. And shall we consider only the quantitative part, the physiological improvement, or the qualitative part of or both? This is another one that we need to discuss. Coming to the non-maleficence means do no harm. So here, breaking the bad news is a topic that we can talk in length. There are many models added to do that one. That will, again, if we don't do it properly, it will harm the patient, will increase the suffering of the patient. And then non-beneficial treatment or futile treatment, that is another issue, because if we give it, it is causing more suffering to the patient. And then euthanasia is another one. There's lots of controversy, and when we talk about euthanasia, we need to think about the interface between euthanasia and the legality of that country or the state. And then palliative sedation, there is something called doctrine of double effect that I will be talking later. And in coming to the justice now is about equitable access, quality of care. Just now we heard from the Tamenglong is about equitable access. It is not there, so we need to improve that one. And whoever gets it, it should be with quality again. So it should be ensured. That's about the justice. And consideration of the opportunity cost, I'll be talking together with the last one. Ensure effective use of resources. India, I don't think that we have a statistic. I don't find anything. But in the Western countries, they have a statistic. For example, of all the health budgets for the end-of-life care, it takes around about 10% of the total budget. It's a huge one in 1 year. But if you consider for 3 years, it takes about 25% of the whole budget. And for what? For prolonging the life a little. Because there is no productivity in terms of the development of the country. So people are questioning whether we should be investing that much of money for nothing, for no development in the country. That is something that they are talking about from the resource point of view. That is a question of justice, because this money we could have invested in some other program to save thousands of lives. So we are using this money here for nothing. That is a question, and that is what we call as opportunity cost. Now, end of the life care. Now, coming to the end of the life care, there's a concept of good death, a bad death. So what is a good death? Good death means it should be comfortable and controlled. So when we talk about it, we should be taking into account what the dying person wants. So it's about appropriate and decent death, and Institute of Medicine, USA, they define it as one that is free from avoidable distress and suffering for patients, families, and caregivers, in general accord with the patients and families' wishes, and reasonably consistent with the clinical, cultural, and ethical standards. So this is the concept of good death. And this is the framework for good death. That means in order to bring about the good death, we need to talk about, or we need to consider all this. So first is the fixed characteristics of the patient, which we cannot modify much. That's about the demographic characteristic of the patient and the condition of the patient, and there are modifiable experiences of the patient. For example, physical symptoms can be modified that the patient is suffering from. The social support system that we have, more supports means better. And then hopes and expectations. People have hope and expectations, and doctors do not try to destroy it at all. Of course, there are lots of controversy in it, but they survive with hope. So that's something that we need to talk about. Then psychological symptoms, again, they have, so it can be modified by proper intervention. Then economic demands are there, and then spirituality and beliefs. All this has to be addressed, can be modified to bring about a good death. And lastly, we have the care system. So the social interventions are there. So if we have a proper social intervention, it can be a good death, and a caregiver intervention, and hospital or the institution's intervention. If we consider all these things, that might lead to what we call as a good experience of death. That is the concept of good death. And all these things attract ethical issues. Now coming to the ethical issues in the end-of-life care. So the first one is the triggers. These are the triggers. And these are the patient's perspective. This is the surrogate, the family's perspective. This is the healthcare provider's perspective. And this is the institution's perspective. So the first one, when the trigger is, there is a request for non-beneficial treatment. That is what we call as futile treatment, which is very controversial, of course. And then from the patient's perspective, they think that is useful. So that is what we call as therapeutic misconception. And from the surrogate's point of view, is a sort of illusion. It's going to be good for them. And from the provider's point of view, it is a miscommunication. They fail to communicate to the patient that is not going to do any good for them. And from the institute's perspective, there's a lax policy regarding the end-of-life care. And in terms of the second one, that is the excessive end-of-life care. When patients demand lots of this end-of-life care, maybe because of the lack of understanding from the patient's perspective, from the surrogate's perspective, is a burden to decision, because they need to take series of decisions together. And then from the provider's point of view, is a tyranny of the autonomy. That means over-exercising autonomy. What the patient wants, you have to do is, they want so many things, there's a tyranny for them, and of course, they will give them the moral distress. And from the institute point of view, that could be a problem in the trials of the ICU. Refusal of the analgesics, sometimes some of the culture believes, they think that they don't want any analgesics because they have committed, or the person has committed a sin before, and now he is penance. That is redemptive. So that is the patient's perspective. The surrogates, the family member, after seeing the pain, someone, loved one is suffering from pain, they feel guilt about it, and provider also have the moral distress because they can't do anything. They want to do, but they can't do anything, so they have the moral distress. And from the institute point of view, there should be a menu approach to the EOL, the end of life care. That is nothing but the patient care, or patient-centered care. Then withholding of the life-sustaining therapy, again, from the patient's perspective, it could be lack of advance directive or living will, and it could be a disregard to advance directive when there is a conflict. Patient already want that if I'm in that condition, let me die peacefully, don't put any machine to me, don't do any DNR. But the family wants it, so sometimes they disregard that one, that's one. And from the provider's point of view, the fiduciary duty, when they withhold that one or when they withdraw those support system again, they feel sort of guilty that because they have a duty towards the patient, that is what we call as fiduciary duty. And then from the institutional point of view in the justice, the one I was talking about, there's a lack of resources. These resources could have been used somewhere else instead of to this patient. This is about the framework of the ethical issues in the end-of-life care. Now, understanding the challenges and conflicts in palliative care, this has been already highlighted, so I don't need to highlight once again. Because of the socioeconomic barrier, poor people has less access. Definitely, it may be because of the geographic limitations, and then it could be interplay between the culture, beliefs, and religion. Sometimes patient doesn't want it, but it is going to be useful. Sometimes they want it, and it's not going to be wanted, but it's not going to be useful. Patient doesn't want it, but it's going to be useful. Those are the situations. Then ineffective coordination, collaboration, and teamwork. That is, again, another hurdle in the palliative care. And timing, to talk about the end of the life care, and it's a very complex phenomenon, and it's very difficult to talk about it, and these are the situations out here. So this is the clinician's perspective, this is the patient's or the family's perspective. Here in the middle, the patient is there. So from the perspective of the clinicians, so there's a continued pursuit of medicine or disease control, the ethical consideration, uncertainty is there, then confirmation bias. That's something that believe that is going to happen in that way. And the same thing from the other side, they have all these beliefs that anticipatory grief, and they have the magical thinking that is going to recover after some time if we do this one. So these are the issues, and the provider has to think of all these issues and have a proper dialogue with every stakeholder in order to talk about it. Then doctrine of double effect, as I was talking about, at the end stage, for example, in cancer, patient has terrible pain. So in order to remove this pain or alleviate this pain, they give sedation. And usually they use opioids. And when they give opioids again, the safety margin of the opioid is very narrow. That means if you increase the dose a little, it will lead to the death of the patient. And if you reduce the dose again, the pain is not going to be relieved. So that is a confusion, or rather the ethical issues in it. So if you increase the dose, the patient is going to die. So the question is, when the doctor or the family member wants the patient to die, they might use it as a sedation, but their primary objective is to end the life. So there is a thin line between that one, whether you are using it for sedation or whether you are using it for ending the life. So it is up to the human being, the one who is thinking about. Of course, there could be professional mistakes and all, but still then, this is an ethical issues. Very important one in the Western country. Usually they talk a lot about this deep continuous sedation of the patient. And next one is about issues in conducting research in the end of the life care again, because dying patients are especially vulnerable, informed consent may be difficult to get, balancing research and clinical role is particularly difficult, and risk and benefit of palliative care is very difficult to assess. So these are the issues in the research, and again, without research, again, we cannot advance the end of the life care or the palliative care. We need research, at the same time, it's very difficult to conduct research among these people. And Providers burnout, I think this has been talked about. We have to look into these issues also, the blurring of the boundaries between the empathy, that we need to show empathy, but at the same time there is a professional boundary, so how far we need to go, that is also an important consideration to be met. The provider needs self-care. Conflict in decision making, this is what I'm talking about. I have 1 or 2 slides after this. The decision should be in the best interest of the patient, considering their cultural background, beliefs, religion, and personal preferences. This is what it shows. It talks about this autonomy. Now, where the conflict can happen? Individual versus the family members. The decision between the individual patient and the family member, they are in disagreement. So doctor doesn't know what to do. There is a conflict, is a situation. And then advance directive versus family. Advance directive, patient has already said that, no, I don't want to be resuscitated. I want to die peacefully. Don't give any ventilator, something of that sort. But family member doesn't agree with that one. Again, doctors are in confusion and dilemma what to do. So that is another conflict that we can have. Another conflict is healthcare provider and individual. Individual denies the treatment, but doctor thinks that it's going to be useful to elevate their signs, symptoms, or prolong the life a little meaningfully, but the patient denies it. It's his sort of redemptive one that I was talking about pain relieving. So there is a moral distress for the doctor and a conflict between these two decisions. And same thing, healthcare provider versus the family, healthcare provider versus the individual again. In a way, healthcare provider, they cannot exactly deny, but to them, they feel like denying it, but the patient wants it. That would be in terms of futile treatment. No benefit for the treatment. As a doctor, we know it. As a healthcare provider, we have all the evidences to talk about it, but it's not. So, but the patient wants it, or patient family wants it. So these are the situations. The last two is about the patient's family. Same thing with the patient. So there's a conflict in this decision. And it's very difficult to resolve this conflict. The best approach is to have a multidisciplinary, multi-sectorial team, have a thorough discussion, dialogue, and come to it. There's no straightforward answer to all these conflicts. So it has to be resolved through dialogue only, but it should not be only one person, it should be multi-sectorial. When I say multi-sectorial, it's not only the healthcare providers. You should be involving the ATCs, you should be involving the social worker, it should be involving lots of other people from other sector. That is a team, and most of the Western society, they have this team, but in India, I don't know, I'm not aware of having any, might be few, if at all, if it is there, very few of them might be having this sort of clinical team, ethics team. Now coming, just 2 examples. One is about withholding all the life support system. That is the case Entry University Hospital versus David James in 2013 in UK. So there is a futile treatment. The hospital doesn't want to give it because of the resources especially, but the patient family, they want it. So hospital went to the court, hospital went to the court of protection, and the court rejected it. And they went to the appeal court again, but again their decision was upheld. That means you can withdraw the life support system. And James died meanwhile in 31st December 2012, but UK Supreme Court again took up the case in 13, and they supported the plea of the hospital. That means withdrawing the life support system. So there's always a controversy in ethics as well as in legal system. And there is a famous case in 90s that's called Terry Schiavo case that happened in US. This is a world famous one because there are more than 30 litigations and pleadings involving governor, involving the United States President, George Bush was there. But that I'm not highlighting here, I'm highlighting a case from India that happened in Mumbai. There's Aruna Shanbag versus Supreme Court 2011. Aruna Shanbag was a nurse in the KEM hospital in Mumbai, and she was sexually assaulted in 1973 by a janitor of the hospital, Solanki, and she was in the vegetative state, not the persistent vegetative state, for 42 years. 42 years in the hospital. And she died, of course, in May 2015. So in December 17, 2010, one journalist, editor, Pinky Birani filed a case in the Supreme Court saying that Aruna Sandberg is my friend and she wants to end her life. So she pleaded for her in the Supreme Court, euthanasia be done there. And Supreme Court appointed 3 panel doctor, I think 2 are from AIMS, and they were told to examine the case. And because of technical reason, the doctors opined that CE is sort of persistent vegetative state, but not actually vegetative state, because only in
Dr. Brojen, I'm afraid you have to conclude.
Yeah, I'm concluding.
Already 1 minute over.
Yeah, I'm concluding. So finally, Supreme Court rejected the plea, but they agreed later on that if at all passive euthanasia has to be done, they can do it. But later on again, the case was fought again, and in conclusion, so it's very important that we understand the ethical principles, and again, it is very important that we consider patient's perspective, the beliefs, culture, religion, and at the same time, it is very important that we have a multidisciplinary, multi-sector team to address the palliative care issues, and of course, we need advocacy for palliative care, advocating to the patients or public, advocating to the policymakers, and advocating for equitable, quality palliative care. Thank you.